in this Q&A session, I would like to introduce Kasia Peters, who is a children's neurologist in the Netherlands, in the Leiden University, who has a really great, large experience in also counseling parents in antenatal, if we find antenatal abnormalities. So it's good to have you here in our discussion session. We have had some questions from the audience, and let's begin with the first question. That is, well, thanks for the great presentation. My question is, how common actually is fetal infection in isolated fetal growth retardation if there are no additional abnormalities at all?
I think it's actually quite low. So it is true that the workup for small babies, according to all the guidelines, would actually include testing for TORCH or testing for maternal infection. But actually the yield, the chance of a positive result is really, really small. I would say less than 5%, even less than maybe 2-3% if it's truly isolated. Of course, isolated, I mean, I think I would prefer to use the term apparently isolated, because isolated at 20 weeks might not necessarily be isolated at 30 weeks, and also depends on what the level of the detailed ultrasound or MRI that you have performed to rule out associated abnormalities. So I would say the yield is very small. And particularly, again, I think it's like, I don't think we have a really robust data, whether it's early onset or late onset. So I think it's, of course, more likely if it's an early, for example, in absence of Doppler or evidence of placental insufficiency, compared to the late where, you know, for example, the baby's small, but everything else is fine, and maybe constitutionally small, or very typical features of placental fetal constriction with abnormalities in the fetal Dopplers and the trans Doppler. So I think it depends, but I think it's very low.
Okay, thank you. And then we move on to the next question. I think that's also for you, Asma. If we have neurosonomarkers of mild infection, is there a benefit to use valacyclovir, or is it just a preventive treatment?
I think it's a really good question, because and that's why I added, I included the slides, because I think it's an area where I think people are really keen to know what the data shows, what the evidence or the recommendation for your everyday practice. So what we know for sure, that the randomized controlled trial, it's a prevention of maternal fetal transmission following maternal primary CMV infection in the first trimester or in the periconception period. We showed you the evidence of giving valacyclovir in mild or moderate infection, fetal infection. And in fact, it does look promising. It seems that it maybe reduces a chance, or associated with a reduction in the chance of being symptomatic at birth, but just with the caveat, this was not a randomized controlled trial. This was phase 2, and in fact, what the team did is they compared the outcomes of a group of pregnancies that received the treatment versus a group of historical controls that did not have the treatment. So you can see that actually, obviously, there is not a strong evidence. So back to my practice, I would actually consider it. I would discuss it with the patient. I would be honest about the level of evidence and recommendations. From my experience, almost all patients do ask for it. Even if you don't mention it, they will go and look on the internet or contact someone, and they will come back to you and say, "Doctor, I heard about this treatment. Can I have it?" And it's a balance between benefit and risk, is it? So there is reassuring data on its use, apart from obviously the risk of the maternal renal function. So you need to monitor for that. But actually, overall, I think it's relatively safe drug to give, and there's potential benefit. Again, back to the point of working within a multidisciplinary team. And over the years, I think I learned, obviously, from the virologist and other members of the team. And I think the virologist I work with, he used to say, actually, it will not repair the damage that already occurred, but the valacyclovir might be useful in stopping further damage or suppressing the virus, essentially, and that might have some benefit. So he himself, despite the fact that the level of evidence was not great, he himself was actually quite keen to offer it to the patients because of this potential benefit of suppressing ongoing activity of the virus.
Yeah, it's really interesting what you tell, Asma. But I had a same question. Shouldn't we give it as well to severe infected patients?
Oh gosh, oh my God, this is a very good point. And in fact, I had few slides with actually a couple of cases that I have come across in the last couple of years where this precise scenario, and I removed them because of the time. But the precise scenario that the cases of severe fetal infection, there's already brain abnormalities, already there's multiple abnormalities. One of them was actually the case that I showed at the beginning. And we don't really recommend it because there's no evidence to say that this is beneficial. But certainly these cases, the patient, they themselves, they really demanded the treatment. And to some extent, the rationale was actually quite. I could not argue with it because both of them could not terminate the pregnancy for whatever reason, ethical or religious reasons. And they said, "But doctor, I'm going to have the baby anyway, so at least I can do something to maybe reduce the severity of the infection." And despite the fact they say, well, there's no evidence that it reduces the severity, it might not benefit, they still really wanted to have it. And in my practice in the UK, we tend to have a multidisciplinary team discussion because it's outside the protocol. And if the team would support giving it, we did give it. And I discussed with the patient, I said, like, my concern of giving it is that you might actually convert a case where the fetal infection is so severe that the baby will die. Whether intrauterine death or neonatal death, actually a baby that would survive but with severe disability. And I'm not sure that this is actually doing benefit to the baby or the mother. But both of them, they insisted on having it. So they had treatment. And unfortunately, one of them, the baby actually died. And the other one, the baby is alive, but really severely disabled.
Yeah, I have the same experience because I also had such a case with a severe infection with a large suboccipital cyst and severe cerebral impairment. And then the parents argued, so if we have a baby who's not able to see very well, but why shouldn't we save the hearing? Because otherwise you have a really disabled baby. So if the parents really would like to go on with the pregnancy, I think you might consider it even in severe infection. It's really interesting. But we have a lot of more questions. Wendy, please.
Yes, perhaps we go further with the next one. When the head circumference is below the third percentile of even the first percentile, as an isolated finding, so no history of travel or anything, can we reassure parents and just offer monitoring for growth? And actually the same question for if the cerebellar diameter is small.
Do you mean in the context of a congenital CMV infection?
I'm not sure. I think in general.
Okay, well, I think that's
a question, right?
Yes, I mean, I guess it's probably in the context of infection because that's the topic. But actually, let's say if general, if just a baby have a small head or microcephaly, I think it depends on what else is going on. It depends whether there are associated brain abnormalities. So that will be obviously an indication for detailed neurosonography and doing MRI. So then we do an MRI in our practice, and even we repeat the MRI throughout the pregnancy. And then, of course, with a test for genetic abnormalities, if you have completely isolated, so just the only thing you find is microcephaly, in this case, it depends on the progression. So if this head started slowing the growth, it's not growing essentially, that's a primary microcephaly, and unfortunately the prognosis is guarded. So there is a risk, of course, of neurodevelopmental disability. But actually, if the head is continuing to grow and the rest of the baby is completely normal, and all the tests, including TORCH, including genetic testing, exome, have not revealed any abnormality, I think cautiously optimistic, but with obviously with a huge sort of caveat of a bit of doubt, because they cannot be 100% certain. But I think certainly if it's a primary microcephaly, you'd expect that actually the gross velocity of the head circumference would show a reduction, which will slow even further slowing compared to just being, let's say, three standard deviation below the mean. For the cerebellum, is a completely different story, and again, it's a different story whether it's within the concept of actually having a congenital CMV infection, or it's just isolated, or this is the only thing. And of course, within the context of CMV infection, it's one of the brain abnormalities. Often will be associated with other brain abnormalities. I think it's not common that you just have small cerebellum and CMV. But if it is not within the context of CMV, you worry about cerebellar hypoplasia. And cerebellar hypoplasia itself, whether just the cerebellum or pontocerebellar hypoplasia, and of course looking at the vermis to try to figure out. And therefore, there's a whole workup for small cerebellum or potential cerebellar hypoplasia, which can vary in terms of the prognosis depending on associated abnormalities and etiology.
Yeah. Maybe I can add up a little bit, because in general, if there's microcephaly, I think even if you're a gynecologist and seeing that patient, that mother, please take the head circumference of the parents, because often it's just inherited, and it's a microcephalia vera, and you're looking just to a small head. So
yes, you're absolutely right. Yes, I forgot that, because actually I do, and I bring a tape and measure the parents, and often actually one of them have a really small head.
Yeah. Mm-hmm.
And at least that's reassuring.
Yeah, you're right.
Okay, thank you. So then the next question, do you recommend a universal screening program for CMV during pregnancy?
Oh, wow, that's a $1 million question.
Yeah.
Because it's really controversial. I work in the United Kingdom, and therefore at the moment we don't have routine antenatal or prenatal screening for CMV. I think that might change. I think they're looking at it. I think it's difficult to say. I think it will take time to review the evidence, but unlikely to be the case in the next couple of years. While I know that there are other countries where they have already started routine antenatal screening for CMV, particularly on the back of, there's been, in the last few years, there's been a number of recent development related to CMV, which I think could hopefully make a strong case for offering routine screening for CMV in pregnancy. And one of them is the valacyclovir, the trial that I showed in my talk, which is from Israel, which showed that if you diagnose maternal primary CMV infection in the first trimester on the periconception period, that you have intervention to reduce the transplacental transmission. So there's now potential benefit of actually finding out. And then the other thing, which is also in the last few years, is the fact that there is evidence that it is really mainly the CMV infection in the first trimester or in the periconception period that is associated with embryopathy. And that means that if we can just screen early in pregnancy and there's no evidence that the mother had CMV conversion or CMV infection, we don't have to worry about the rest of the pregnancy. The most recent evidence, which I did not include in my talk, is actually come from your country, Wendy, from the Netherlands, about the cell-free DNA for CMV in the maternal blood, which appears promising. So whether actually rather than relying on the serology alone, which can be quite difficult to interpret, is actually looking at the virus in the maternal blood. So Some countries, I believe, I know that France is looking at it because I've been contacted by their national screening committee equivalent for like expert advice. I know that Italy, I think they have, I believe they have, or I heard that they have, but I think many countries, most countries, including Canada, including UK, I think including the Netherlands, which at the moment is not routinely recommended.
Okay, thanks. I think that wraps it up on this topic because it's always a discussion. We only have about a small 5 minutes left. Perhaps it's good to give Kasia the opportunity to talk a little bit more about what is her experience about the neonates which she's encountered with after we have found an antenatal infection. Kasia, could you tell us a little bit more about that?
Yeah, I can tell something about my experience as a pediatric neurologist. Often we do, together with the perinatologist, we do the counseling of the parents, and then we see the babies, and when an MRI is being made, most of them at 30, 32 weeks of gestation, fetal MRI, and then we see them at the neonatal unit. And of course, of all patients that have a congenital CMV infection, about 85 to 90% is asymptomatic at birth. But those children who are symptomatic at birth that are seen by the pediatric neurologist. And what we often see is that they are quite hypotonic, so they have slipping through when you take up the baby. And when we see enlarged reflexes of the knee tendon reflexes, then we also order a neonatal MRI. And then often we find little heterotopias or calcifications or more extensive damage than we thought from the fetal MRI. And what's then important when you let the baby go home with the parents? I think it's extremely important to counsel the parents how they can recognize seizures, because I think that seizures are really often overlooked. And then sometimes we see back the patients when they are 3 or 6 months old, and then we see those gazing moments. So you have the babies. Babies shouldn't gaze at all until the age of 1 year. They always should be active. So when you have a baby who's just falling silent for 5 to 10 seconds, and then it's really suspected of a focal seizure, and you should perform an EEG. And also, because we know that infantile seizures, West syndrome, is also occurring in the severe affected CMV patients, I think it's also really important to counsel patients how to recognize. So that's not a reflex, a Moreau reflex, but if it comes repetitively after each other, then it's a kind of epilepsy, and that should be treated really quickly to improve the later diagnosis. But also even at school age, we know that there are a lot of problems, not only for the cerebral visual impairment, but also if it's combined with unilateral or bilateral hearing disabilities. And also socially, we see at a later age, we often see a lot of problems in children with symptomatic CMV. So I think those children really need to be followed up for longer time periods, and that's really important. I see I have only 1.5 minutes left, and I would like to ask Gregor a question about this excellent talk about AI and in MRI imaging. And of course, the Diogo score has my attention, and I really think it's important. So, but we see when we do the Diogo score in patients, we also see that there are a lot of patients that have a low Diogo score, but do have genetic anomalies. Can you expand a little bit on that, maybe?
Yeah, thanks for the question. Well, I'm trying to point out that this is a risk score. In clinical medicine, if you're looking for a pulmonary embolism, you have risk scores for that. Of course, by looking just at the brain, even post-mortem in utero with the highest possible resolution, you cannot tell anything about function of this organ. This is a principle in nature, and we will never be able to do that. But we can get an idea of kind of a likelihood how and I would like to turn this around. I think how many patients we have seen with a high Diogo score doing normally. And I think that is the point. We are not talking about those with a low Diogo score being perfect. We're talking about those with a high Diogo score not performing. And there, I think, is a very low likelihood that you have extremely well-developing baby with a high Diogo score.
Great. Thanks for this remark. It's important. Thanks for this session. I think it was really interesting to talk about infections. And I see there are still a lot of questions in the app. I don't know, Esma, if you want to answer them on the chat or how we're going to do that.
Well, I think, I'm sorry, Kasia, to interrupt, but I think we have to wrap up because our next session will start at 4 o'clock. So and we can write answers to the delegates if that we could do behind the screens. But I think for now we have to wrap up, and I think also, as you said before, that we had a really interesting session to this third session, and I would like to thank all the speakers. I'm sorry, and all the delegates to ask so many questions, for which we had a really interesting discussion now. We're going to close this session, and then we will go on with the program, as I understand correctly, on 4 o'clock. So we have a really brief pause, get something to drink, and then we will see you back at 4 o'clock.